Jai Bharati.
Good evening, sir.
Good evening.
So, can you hear me, sir?
Yeah, I'm able to hear you. Go
Okay.
ahead.
Shall I start, sir? So, my case for today is a 9-month-old male baby weighing 8 kg posted for bilateral CTEV correction. Master Rahul, 9-month-old male baby, came with the chief complaints of deformity of the feet since birth, history of presenting illness. The mother noticed deformity of both the foot since birth, which is non-progressive, and correction attempted by manipulation from birth and serial casting was insufficient. No other associated anomalies of the face, upper limbs, trunk, spine, and knees were found. No history of fever, cough, or recent URI. Past history, there is no history of previous surgery, no history of TB, epilepsy, or congenital heart disease. Antenatal history, mother's age at the time of conception was 25, natural conception, booked and immunized, no history of prolonged maternal drug intake. First 2 trimester was found to be uneventful and oligohydramnias detected at the third trimester. Birth history, firstborn, full term delivered by lower segmental cesarean section. Indication of cesarean section was oligohydramnias with the birth weight of 2.5 kg. Baby cried immediately after birth and was appropriately breastfed within 1 hour. No history of NSCU admission, no history of birth asphyxia, cyanosis, or breathing difficulty. Family history, no history of consanguineous marriage, no history of similar complaints running in the family. Developmental history, normal milestones achieved appropriate to 9 months except crawling due to the deformity of the feet. Nutrition, feeding and weight gain is normal for age. Immunization history, the baby is immunized according to age. Allergy history, no history of allergy to food or any other medication. Socioeconomic status is low. Coming to the general examination, the child is alert, active, afebrile, no pallor, ictus, cyanosis, clubbing, or pedal edema. No other associated congenital anomalies found. Examination of the hip and spine is found to be normal. Airway, the baby is made to cry and mouth opening is adequate. Uvula is partially visible. Anthropometric measurements, weight of the baby is 8 kg and height is 65 centimeter. Vitals, pulse rate is 112 per minute. Saturation 100% in room air. Respiratory rate 25 breaths per minute. Local examination of the feet. Attitude and deformity. The child is in supine position. Ankle is in equinus. Forefoot in adduction. Heel in varus. Deformity resembles a clubfoot deformity. On inspection, the anterior superior iliac spine and the patella are at the same level. The ankle is in equinus. Talar head is prominent dorsally. Forefoot in adduction and supination. Foot is short, chubby. The skin over the ankle is stretched. Medially, the foot is adducted and supinated. The medial crease is deep. Medial malleolus is less prominent. Laterally, the ankle is in equinus. No callosity is found over the lateral border of the foot. Posteriorly, the tendo-Achilles is found to be taut and the calf appears small. Deep posterior crease is present and the size of the heel is small. The inspective findings are confirmed on palpation. Range of movements, passive dorsiflexion is limited, pronation and eversion is limited, and valgus is limited. On active, scratch over the foot to check the eversion of the lateral border is possible. Other system examination, CVS S1, S2 plus, no murmurs. RS normal vesicular bronchial breath sounds spread, bilateral air entry equal and no added sounds. Per abdomen soft bowel sounds heard and no organomegaly or free fluid present. Summary, a 9-month-old baby, old male baby presented with the deformity of the feet since birth. Examination revealing the ankle in equinus and forefoot in adduction and heel in varus with no other congenital anomalies. Probable diagnosis congenital talipes equinovarus. Came for the surgical correction.
One important thing missing in this history taking.
Yes, sir.
What have you missed in the history taking? Is it straight away coming for surgery or any other conservative methods tried in the earlier?
Sir, I mentioned in the history of presenting illness, sir. In the past history, he has went for correction, which was attempted by the manipulation by the mother and also serial casting, but the deformity is resistant.
Okay, right.
Get correct.
Then I did not get that right. So that is the important thing. In many of the deformities, especially unilateral support, are amenable to treatment right from the date of birth if they are diagnosed. Because at the time the tissues are all very malleable and supple. So the majority of the clubfoots are corrected by serial casting. Who is the person who introduced the casting? Any idea? What is the name of the person who popularized that conservative method of serial casting and stretching?
Ponseti's.
Ponseti's. Very good. It is called Ponseti's method of correction. Okay, right. Okay, now the patient has not responded to the treatment. It has gone up to this level. So it requires a soft tissue release and correction. So how are you going to anesthetize? This is a short case scenario. So they may. What is the importance of the birth history? You have said that the patient is a full-term normal delivery, isn't it?
Yes, sir.
So what is the supposing this person baby is born at 34 weeks? Does it have any bearing for this surgery now? It is a premature baby.
Premature.
In NICU, and then they noticed this deformity also. Then the child started growing normally. And at 9 months, if this child is posted for this surgery, is there any risk associated with the prematurity of birth and the surgery?
So in premature babies, the risk of respiratory reserve will be less. So
what is
risk
the
of desaturation will
there is a particular name for that. What is that? Apnea of prematurity.
Apnea of prematurity. Yes,
that is a very important term that we must remember. It is called apnea of prematurity. So children who are born prematurely and come for surgery within the first 15 months post birth, within 1.5 years, 1.25 years, they are likely to develop, even though they may appear normal, they may go for what is called apnea of prematurity in the post-operative period. So all these children who have a birth history of prematurity should be monitored with a pulse oximeter at least for 24 hours post-operatively. However much they may be active, alert, and recovered very well, they suddenly may go for hypoxia, bradycardia, and arrest. So this is what is described as apnea of prematurity. Any drug which can be given as a prophylactic measure?
NSAIDs can be given. NSAIDs can.
NSAID. Yeah, NSAID do this. You need a respiratory stimulant to keep the respiratory center alive because it is a central activity. Caffeine. They have advocated caffeine 20 milligram per kg as a prophylactic measure in patients who are born premature and coming for surgery within the first 15 months of post delivery time. Okay. Now, how are you going to anesthetize this child? Supposing this is posted for soft tissue release and bone fixation, everything, galactomy and all that. So, how to do the anesthesia?
So I would like to investigate the patient, baby, sir. The investigations: complete blood count, coagulation profile, blood grouping typing, and cardiac evaluation to rule out any congenital heart disease or anomalies, and X-ray of both foot to confirm the diagnosis, sir. And after obtaining proper consent from the mother and explaining the plan of anesthesia, I would explain the fasting guidelines to the mother and the nursing staff. Since it's a 9 months baby, 2 hours for clear liquids, 4 hours for breast milk, and 6 to 8 hours for formula and solid food. And once the babies arrive to the theater, I would like to pre-medicate the baby to alleviate the stranger anxiety and crying of the baby. So I'll give oral midazolam at a dose of 0.5 mg per kg. Or IM ketamine also can be given at the dose of 2 to 4 mg per kg if IV access is not obtained. Once the baby is settled, the baby is taken inside the theater. And I'll make sure that the workstation is checked and all necessary anesthetic drugs and resuscitation drugs are loaded according to the weight of the baby in appropriate doses. I'll make sure appropriate size mask, laryngoscopic blade, and difficult airway cart also kept ready, since this is a congenital. Then there may be difficult airway also associated along with this disease. And standard monitors are attached to the baby. The ECG leads, pulse oximetry, BP, and precordial stethoscope are attached to the baby. I would prefer inhalational induction if IV line is not secure. I would prefer sevoflurane induction. And once the baby is settled, and I will give IV induction drugs. Propofol at the dose of 1 to 2 mg per kg. My plan of anesthesia, if this is soft tissue release, according to the duration of the procedure, I will go for general anesthesia with the caudal block with controlled ventilation using an LMA or ET tube. Caudal first, after the airway is secured, after injection with propofol 1 to 2 mg per kg and fentanyl at 1 to 2 mg per kg, and the scoline can be given at 1 to 2 mg per kg. Airway is secured using an ET tube or an LMA. Once airway is secured, the child is put in the lateral position and a caudal block is given. Using the modified Armitage formula. Since the baby is 8 kg, I would like to give 4 ml of 0.25% bupivacaine with or without additives.
So it is better to say what is your plan at the beginning.
Yes, sir.
If it is a short case scenario, the examiner may not need you to say I will fix that and all that. They will expect you to say what is your plan. So this can be done purely under caudal with sedation or caudal with full VA control with CT distribution or LMA, or all these things are possible. Depends upon the surgeon whether he wants to do both the foot in one sitting or whether he wants to do only one leg first and then the other leg later. All that has to be taken into consideration.
Okay.
And all these things you must, for the history you have to ask is whether there is any history of any muscular dystrophy or malignant hyperpyrexia in these cases. All these musculoskeletal disorders, better ask the history of any malignant hyperthermia in the family. So that is a very important point that all of you must see. And let's go.